Hi everybody, I'm Kira Ochoa. I work with the Santa Fe County Healthcare Assistance Program. And we at our table are all county people. So we have Doña Ana County and San Juan County and Santa Fe County. And what we talked about first was how counties could help with the assessment here, that we could think about how to use county programs for information gathering as well as we do for outreach, that it goes kind of both ways. And we talked about the New Mexico Association of Counties possibly working with maybe Nadine, I don't know if you want to help us get some kind of survey that would be uniform throughout all the counties to use in our mailings out to county residents, in our interactions with county residents via public housing program, DWI, teen court, homeless programs, food programs. You know, the counties run a lot of these similar programs. We could have some kind of survey that we could both mail out, but also maybe use with people that we sit and talk with, or our people sit and talk with some fields for qualitative as well as quantitative information. Might be really cool. And so that's mainly what we talked about in terms of, we also talked about on re-enrollment, when we're doing re-enrollments with folks, just asking about their experience with either Centennial or HICS, insurance programs. So that was what we talked about in terms of what our organization could do. We'd love to see, if on re-enrollment, we'd love to see the exchange and ISD also be asking about people's experience. That'd be cool. You can dream, right? I mean, you can hope and focus. And then in terms of who was not at the table, forgive us if you are here and we didn't know this, but we talked about the public health offices, county, DOH. I'm not looking at you, but yeah, I'm looking over you. Then the hospitals, consumers, maybe more consumer representation would be nice, and how that happens, I don't know, but HSD, ISD, we love that the schools from Albuquerque were here. We'd love to see more schools, and Lisa Garcia suggests, Gomez, sorry. We have Lisa Garcia in our office. Suggested that the New Mexico School Board Association might be a good group to get here or in this loop. For-profit QHPs could be here if they're not. Molina was here, I think, but the other ones should be here. We talked about New Mexico Corrections and county detention folks maybe getting here. There was that new law passed recently where Medicaid in the jails will be paid, which is a great thing, but still there'll be a need for enrollers in the jails. And then also just what do you do once you have insurance question for people who aren't used to it? That's a population that could really use that. And then we also talked a lot about aging long-term care people, that it would be nice to have ALTS in this loop, and also then this leads into our other issues, which were many. We talked about wanting to understand the special cases around enrollment in Medicaid and exchange for undocumented folks. We understand there are some special cases, and obviously there's been emergency Medicaid for many years for that population, but is there ways for them, are there ways for them to get on the exchange, and what are they, and who can, who can't? Seniors, obviously people with not enough quarters paid into Medicare, and how they may be served by the programs. I'm wanting to get maybe mini training by NMPCA, Alberta, at the New Mexico Association of Counties meeting maybe. Tax subsidy information, understanding these penalties. This is stuff we wanted to understand more. Assessment. Finally, we wanted a live chat line. We got into a wish list of things we wanted. Kind of like, how do you enroll this person in this, or why is this person getting kicked back? Like, wouldn't it be great if the exchange could fund something like that, where there was just continual support for everybody doing the enrolling? And then also, finally, we talked about how assessment means gathering, but also disseminating, right, the information. And we're all really impressed with the NAPR model and would love to get that, learn more about how to do that in our own contexts.
Who's ready to go next? Mike?
That is what is known as a tough act to follow.
Yeah.
I'm Mike Parks. I'm with the Senior Citizens Law Office, and basically our interest in the ACA specifically has to do with a narrow slice of the pie with the other adults coverage, people in the 60 to 64 age range. So as a result, everyone else at my table was with NAPR, so that the type of issues of concern, because the people at NAPR are very knowledgeable about many of the questions that you folks at the first table raised. So the range of issues that came up was smaller because the group is so knowledgeable about most of the issues we would talk about. So in terms of voices, obviously the contractors of NM Hicks who do outreach and enrollment should clearly be voices at the table, but I think the group also thought that it, either at the same time or preliminarily, it would be good to have many organizations, or all the organizations that get money from NM Hicks for doing this kind of work, should themselves convene in some way and share concerns about common problems and solutions, things like that. And for example, it was pointed out that in a particular area, someone might be doing this type of work and not know who else was doing it in the same city. So that kind of sharing and getting to know one another and pooling ideas was seen to be an important voice for the assessment. In terms of people not at the table, tribal governments was one of the first that came up. HSD, because they're obviously involved in a lot of information sharing to the extent that they share information with us ever. Those of you who deal with that know what I'm talking about. But I'm sure they'll change with the weight of authority in this group. So it was thought that also there's a need for a lot of medical providers' involvement, the hospital association, different medical groups, because they really know firsthand issues about lack of sufficient provider resources to serve all the people that are coming into the system because of extra help, the expanded Medicaid and what have you. So in terms of other issues and needs, this was, again, somewhat specific to NAPR, but I think it applied generally to folks because, as many of you will know, NAPR has the contract with NM Hicks to have a walk-in center that anyone can have access to, and apparently the funding for that may be dwindling out, if not ending this summer, and something like that is really needed. So there's this other issue of having a service like that continue.
Thank you. Who's ready to go next? Great. Oh, you were. He's closer. I hope that's okay, Dick.
Thanks. My name is Eric Lujan, and I'm currently with NAPR. I'm an enrollment counselor. And we came up with all of that stuff too. So I won't go back through that whole list, both groups that went before us. What I will add to that is what you voiced in the assessment. We share current info resource developed. So we would like to see all of the organizations here that create information or information pages, white papers, one-pagers, share those documents with everybody else, so that way everybody knows what everybody else is talking about. I mean, that's part of the biggest problem in this state is everything is siloed. And it goes to the fact that there may be 3 or 4 different agencies in one area doing the same work and not having a clue that that person is doing it. And that's how we run into people receiving misinformation. So you have one organization saying this about the Affordable Care Act, but then you have another organization saying something that's kind of the same, but then the consumer gets confused. Well, is it the same? They don't really know. Okay. Things that we can provide as consumer organizations or as advocacy groups would be consumer stories. That's missing here. The actual consumer of Medicaid, of healthcare services, of QHBs, non-existent here. We have a lot of people that deal with programs, but nobody that actually utilizes the services. Missing groups, missing organizations, Asian community, LGBTQ, provider networks, is this PED, educational field, so more of the schools get involved, but also not just public high schools, but also like universities as well. We have a lot of community colleges that could benefit from this type of information. We think that CMS maybe not have a representative, but at least be notified that this information or this type of work is being done. Somebody from DOH, HSD, of course, but specifically Centennial Care. Hospitals also need to be involved in this discussion. Community health workers, immigrant populations, and then a big long list here. This is stuff that is beyond enrollment or the other things that we're talking about. Mostly, and I'll share this with, we'll give this to you, but mostly has to do with oversight. Oversight of Medicaid, oversight of exchange, oversight of QHPs, and it goes to the Office of Superintendent of Insurance. More oversight both at the consumer level, but also at the top. Behavioral health, lack of providers and benefits. Provider reimbursements are inadequate, particularly around preventative care and reproductive. This is some things that Paige brought up. The reimbursement rates through Medicaid and through the QHBs for preventative care have historically been not enough. And that is why most people don't get them and most doctors don't provide them, is it's not worth their time to give these types of benefits or these types of services because they don't get the reimbursement for it. Is HS doing what it should be, could be doing around the ACA Medicaid expansion? Again, it goes to oversight. Is DOH doing what it should be, could be doing around ACA? Are there potential changes to Centennial Care that would benefit community and be more in line with the spirit of the ACA? What we need is, from the MCO business perspective, what they feel is more streamlined, efficient, what might be, sorry, kind of shorthand. That might also be what is the best interest for providers. So involving the MCOs and carriers. Maybe what's needed is a lot of these programs be more streamlined, that way their administrative burden is lower. Need more funding. Resources around healthcare systems advocacy. We sometimes have to default to supporting individual consumers, and there needs to be better info on systems from the feds, HHS, and state HSDs.
I think Dick was ready to go next.
We're gonna report jointly. I'm gonna do one area and Ron's gonna do 2 others. I'm Dick Mason with the Metro Alliance of Health Councils. I'm gonna be talking just mainly about who is missing from the discussion. State agencies, Department of Health, the Public Education Department, the Higher Education Department, all the other ones that have been mentioned that could help, particularly around doing outreach and educating people about both Medicaid and opportunities on the health insurance exchange. Providers that were mentioned. Agencies and organizations working on workforce development. Hospitals have been mentioned. Legislators and other policymakers are missing. MCOs and carriers, although we have some representation from carriers. One. Grassroots groups that represent vulnerable populations, veterans, faith-based. I mean, that's been absent throughout, and we, you know, that when we talk about people who have trusted relationships with the people who need coverage, those are the people who have it. And tribal leadership. And then Ron's going to talk about the other two areas.
I only have one area.
We have two. Two are.
Oh, yes, okay.
Okay.
Okay, well, the easy question first. How is your organization, how can your organization have a voice in the assessment? And we all feel that all the organizations represented at our table currently do have a voice. The New Mexico Alliance of Health Councils, Health Connections, Albuquerque Public Schools, New Mexico Voices, and Health Action New Mexico. So we're all pretty heavily involved. In terms of issues that were raised or questions to discuss, one was the need to define assessment. That is the kind of the scope of the assessment. You know, we're all agreed. In fact, already a number of issues have been raised in relation to defining the breadth of the assessment. You know, not only enrollment, but the use, what the health plans look like, how people are able to use those health plans. What about populations that are excluded, like undocumented immigrants? And then the basic question of how is the assessment information going to be used? How do we move from a report to policy action? And then the folks from Albuquerque Public Schools, they're concerned quite a bit with eliminating the stigma that comes along with taking advantage of public benefits like Medicaid. And then, of course, we mentioned the lack of mental health services, behavioral health services in the state. And it's just a huge issue that's always in the background of whatever we do. And finally, that we should be incorporating workforce development issues, including scopes of practice as part of the whole ACA discussion. And then, I think we also mentioned this, but I didn't write it down, was that sort of talking about social determinants of health and population health as part of the ACA. And when the ACA was written, that was a huge part of it, establishing a prevention fund that has, you know, to some extent been decimated. But that's still a major area of concern in the ACA. That's it. Thank you.
Ready to go?
So I'll also invite my group to add to anything that I might forget. But my name is Javier Rios, and I work with Strong Families New Mexico, which is a program of Forward Together. And so I formerly used to work for the Department of Health, and so I also have experience, most of my experience in terms of ACA outreach and working at Department of Health. And so I'll start off with the partners that we're missing, and one of them, there are a lot of echoes. Of course, the state health department is not here, HSD, or if they are here, the voice hasn't been heard. Brokers, community members, LGBTQ, CHWs, immigrants, etc., echoing Indian Health Services, more representation from Native communities. And then specifically and especially the people who are accessing, right? People who are accessing the consumers. One of the ways that we contribute and how our orgs can have a voice is by being present and being here. So a lot of us are here for that very reason. And then continuing and sharing the work that we've been doing. We have many, probably our biggest category was the other issues and concerns. So we had everything from a cultural appropriateness of the outreach, language access, which were barriers, people being denied, and then when a person is denied, not wanting to go back, and also go through the whole rigmarole of you went through all this process and then you're denied, so then you just quit or give up. And some people are denied multiple times. So then the understanding that a lot of people are just not going to go back. And also how that's an issue of cultural concern, because there's a sensitivity in denying, especially when you're talking about people's incomes and where all their taxes or whatever information is being collected. And then a huge issue is, so the brokers and the people that are enrolling people should have a bigger role in connecting. Okay, so you're enrolled, bye, good luck. There should be a bigger connection to, okay, here's how you access preventative health care, here's where you should go. Here's what's going to happen if you go to this doctor that's out of your network, and what the cost is going to look like. If you go to a doctor and you've never had insurance and then you get a $400 bill, the likelihood of you wanting to go back to a doctor when you don't have a lot of income in the first place is going to be unlikely. The navigation process is difficult for people who have regular insurance. So for people who have historically been uninsured, making sure that people understand if they go to a doctor that maybe they need to show their insurance card. Maybe the brokers and enrollers can actually refer people to resources in their vicinity. So if you're outreaching in Gallup, where can you access what you're enrolling for in Gallup? What can you not access in Gallup? We also noted that behavioral health, there was a big gap in terms of like, where do people access behavioral health? They can't often access that in rural areas. So where do we tell them and share with them that they can get that? Also, a lot of people who historically don't have insurance don't have that self-advocacy skill, where they're saying, okay, well, if I call and I get rejected, right, that's the end of it, I'm done. Or if I call and somebody tells me you owe $5,000, they don't know to call you and say, help me because this is not correct. So the people who are enrolling people should be giving people these tools or connecting with partners to give people these tools. A huge thing that we talked about was internet access, and how in our rural areas, even if you have internet access on your phone, you're not going to enroll on your phone. If anyone's ever tried to do a huge application on their phone, it doesn't work. And that's also taking into account that you're tech savvy and like that kind of stuff, because a lot of people don't. We talked about the intergenerational use of technology and how some people don't use that technology or may not have access to it. Yeah, and also like really having, we talked about the brokers should be here. People who are brokers should be also able to explain the plans better. So like we said, if you signed up for this plan, it might be the cheapest plan, but if you have a chronic disease or illnesses, all this stuff isn't going to be covered, so maybe that actually isn't your best plan. So XYZ is covered, XYZ is not covered under the plan that you have chosen. Let me see if I'm remembering anything else. Is there anything else that... Oh, we did talk about reimbursement from private insurance, and the exchange is much better, and the issues are better than if somebody has Medicaid. So the complications of reimbursement, it seems like a lot of patients who have Medicaid seem to have a lot more issues with billing and reimbursement. So how does that improve? Yeah, because of the categories. So also, so the Medicaid categories. And then I also wanted to share, like for example, from Strong Families in collaboration with the Alliance for Justice did this report that Adrian has here and can share a lot more about with you, but it also says a lot of stuff about what people experience upon trying to enroll, which a lot of it is exactly what we said here. And knowing these resources that already exist and being able to share them. And so in New Mexico, I think one of the big things too is like we aren't just enrolling people, but we're trying to create a cultural shift of how we access healthcare. And so a lot of people don't, just because they're enrolled now, they have no idea how to access the healthcare that you just enrolled them for. So that piece needs to be better connected. I mean, that's the huge part. Our goal isn't to say, oh, we're like an insurance company, we get a $50,000 bonus for enrolling 500 people. We also want those people to access the healthcare system that they just enrolled for. So just making sure that connection is made while you're enrolling people and not like after a year where they already have a $500 bill that they can't pay and they're frustrated and don't want to access healthcare anymore.
Javier explained so much of what we talked about, but there was one that I can't articulate quite well, but it's those living on the borders of different states. And I don't understand myself. They explained it to me and I still think it seems very complicated. You know, if you're in New Mexico and trying to access Arizona services, or New Mexico trying to access Texas and possibly Colorado as well, that seems very difficult. It's like, it's already hard enough to know where you're gonna go, but then when you're out along the state lines, that's a whole new challenge.
Thank you. And just to clarify, when you're talking about the cross-border issues with Arizona, Texas, and Colorado or Utah, are you talking about access to health coverage? Like how do you enroll, because the Medicaid plan is different and exchange different, or is it actually accessing the health services?
I was talking about the health services.
Health services, okay. Anyone, who's going next? Alberta.
I think they've mentioned everything we have on ours as well. Or how can an organization have a voice? I don't think we really talked about how we each can have a voice. It's more like what we can do to make it better. Making sure that we're connected with health councils, involving additional organizations, consumers, patients, and health councils as well. Once the assessment is done, is doing a briefing to the congressional staff about the ACA assessment and having a final report. As far as the NMPCA, we again track enrollments and wanting to find out where a certain organization that does really well with enrollment, going and finding out what is it that they do, how do they increase their enrollments, how can we learn from them, what are their best practices. Let's see, have Kunama work with grantees to speak with clients and consumers that they serve. The grantees are a bridge to the consumers. The Office of Superintendent of Insurance, Managed Health Plan Bureau, to be able to communicate how we can assist them and make the consumers to be able to communicate how we can assist them and the consumers. They can also share information on network adequacy, as far as needing involvement from input from the frontier communities, because they're underserved, including health councils, schools, courts, elected officials, mayors, council of governments. Also need more involvement from business stakeholders, perhaps the chambers of commerce, brokers, promotoras, community health workers, taxpayer advocates. New Mexico advocates, they could identify trends and make recommendations, so having the tax involved as well with us. Issues to be dealt with, recommendations around providers staying with plans. It's a big issue for the rural areas and access to care. Sometimes they don't have access and they have to come to Albuquerque to access that plan, so keeping providers with those plans. Having pediatricians, the number of providers and areas for the children, and an agency that regulates the policies. I know one of the other things I was thinking of after on other issues is it seemed when open enrollment closed, the whole discussion of insurance closed, but they don't understand that Medicaid is still ongoing regardless of what time of year it is. So it doesn't seem like a lot of the consumers know that they can still enroll or try and enroll in Medicaid. It just kind of stopped. So I think just still keeping the marketing going on enrollment, whether it's Marketplace or Medicaid.
I think we have one more group.
So I'm calling
Action New Mexico, and then we had Ruth from YDI, and Amber, yeah, and she's from IHS. So for Health Action, we thought that our role in this would be consumer engagement, and then youth and Native American engagement, taking those perspectives and then translating them into some useful aspects of the assessment. So some of the issues and concerns that haven't been covered yet, or that we dug into a little bit more, was leveraging the Affordable Care Act to address some of the social determinants of health, and then focusing on ACA provisions beyond just patient protections and coverage. So how we can tap into provisions like the healthcare workforce, research, delivery and payment reform, the medical loss ratio, some of that sort of stuff. And then also strengthening patient protections and coverage provisions. There was discussion today, I think from OSI was talking about some of the in-network and out-of-network issues. And then coverage for undocumented immigrants, and then more focus on behavioral and mental health and addictions counseling. And then as far as who isn't here, we also noted that consumers themselves, getting them more engaged in this kind of process would be fantastic. We talked about college-aged folks, youth, sole proprietor business owners, small businesses that can't provide coverage to their employees, but still want to have that competitive edge with the big employers who can do that, and then environmental groups who work on public health issues. Yeah, thanks.
So do we have any questions for the groups when you listen to what they shared? Anyone have clarifying questions?
I don't have a question, more so a comment of one thing, another issue that I don't think was mentioned, that we tend to, on the policy level, is kind of one of the big factors that we deal with every day, and it's the family glitch. So what's going on with those individuals that are offered coverage at work, but it's affordable for them, but it's unaffordable for them to cover their families, and at the policy level, how is that something that's ever going to change, or has it been addressed, or is it something that will be addressed in the future? Because I know a lot of New Mexicans are left out of signing up for coverage or left uninsured because they fall into that family glitch.
I have a general question for everyone here. Thank you for your expertise. I've learned a lot today. In terms of assessing, it's kind of like assess as you go. And for example, Medicaid reform, other state type of policy issues, we've never had regular data collection or systematic, regular ways to assess cost in healthcare. And the reason why we've been able to do that is because of different grants. So this grant allows us to assess. And I know the New Mexico HICS had some baseline surveys that they did, and they contracted out with all these diverse communities. We looked at those barriers and facilitators. So my big question for everyone is to, in order to help Alma help us move forward and assess as we go, what would be the low-hanging fruit that we could set up in the next 6 months that could build some capacity and data that people could assess as we go after this grant's gone? What would be some low-hanging priority areas we should assess? Because we can't do it all. So I'm just going to leave it open and would appreciate any insights.
I should have raised this on the other points of concern. But I think one of the things, and it's coming up as a question to the New Mexico Health Insurance Exchange, is the amount of money that's spent on the shop operation. There's quite a bit of the HICS budget that goes towards the operation of the business shop, which New Mexico operates by itself. That is the software that they did build. But I think the budget, for next year, I forget, is 1.6 million or something around that, and they have 800 people on the exchange, on the business exchange. And is that really a good investment on the part of the exchange to expend that amount of money to get those few people into the shop? system. So I think it's a question. I don't have a set opinion on it, but I think it's a question that should be answered.
Thanks, Vic. It's Ruth.
Well, my organization, like many of you, was involved in trying to get the CHIP extension for what we hoped would be 4 more years, and we got 2 more years. But since you do have a focus on the health equity of children, I'm wondering, and I hear from Colin here from Health Action New Mexico, that only about 10,000 kids in New Mexico are on CHIP. And I don't understand what that's about, and it seems like that's something we really need to explore if we're going to think about the health equity of children.
Other ideas for low-hanging fruit for the assessment? Other thoughts that can help Lisa define the scope or breadth?
Good afternoon, everyone. My name is Amber Carrillo, and I'm the Affordable Care Act Coordinator for the Indian Health Service. And I'm not sure if this really applies to the assessment, but one of the things that American Indians and Alaska Natives have been experiencing is having providers not recognize their deductibles and cost sharing. So, and I think that's a huge issue, not just for American Indians and Alaska Natives, but for everyone across the board when they have cost sharing assistance. And I think that's really important because those cost sharing provisions are part of an incentive, but they're also really needed to make the Affordable Care Act effective. And so if those cost sharing provisions and if tax credits aren't being enforced and recognized, then we're not effectively using the Affordable Care Act, and so that's where we might find weakness for consumers. And I think that's a really important thing in order for the ACA to be what it's supposed to be.
I'm Joe Martinez with Health Action New Mexico. You know, on the question of assessment, and looking around in the room here today, and it's not a lengthy history that Affordable Care Act has been being implemented in New Mexico. I think what would be very interesting is to bring together a design team to design a timeline that reflects from the very first time that the exchange was starting to be implemented, or even the legislative process that created the exchange, and then some highlights, a timeline, you know, like it's like our stories, the story of the implementation from different voices. Center on Law of Poverty was very involved, the Southwest Women's Law Center, Voices for Children. There's a lot of organizations that have had a lot to do, that it could be a very brief but very instructive timeline, that we construct that timeline, because there were some highlights. There were some victories, there was not some victories. When the governor said, yes, let's be a Medicaid expansion state, you know, that was a wonderful news. And then, okay, now it's going to be implemented. But maybe we could do a design to assess, and let's formulate a little kind of story collection around the timeline. And then along that, I think we can get some highlights of things that have worked, things that have not worked, and things for the future.
Thanks, Joe. Paige just keeps getting in front of you. Yeah. I know.
One of the areas that I think children are frequently affected by are life changes in families, like divorce, or changes in insurance coverage can happen when you have a baby, or you adopt a kid. And so one of the issue areas that I don't think we've paid a lot of attention to, and I don't know if it would qualify as low-hanging fruit, but sort of analysis of who and how people are getting covered during the who have special enrollment circumstances. Because a lot of the special enrollment circumstances have to do with families. And so that might be something, just, it's a half-baked thought, but it would, to me, if you're looking at children's coverage issues, that would be interesting to assess. And, personally, I've done some education with family law attorneys on this issue, and, where new qualification periods come in when families change. But I do think it's an issue area that might, if you're talking about kids and coverage, that might be sort of interesting to survey, maybe legal service providers, civil, low-income service providers, legal service providers on some of these issues. Just a half-baked thought, but yeah.
Roxanne, I forgot to mention, Adrian had some recommendations too about voices that we didn't get to, and one of them was about the gaps in coverage for foster kids. Right now, there's not a lot of help for foster kids right now, letting them know that they can receive continuation of coverage, and some of them are just getting kind of lost in the cycle. So that was one of them that I wanted to just say that echoes what Paige is saying about kids.
Thanks, Denise.
I just wanted to say, I don't know if this is low-hanging fruit, but it would certainly make a big difference if we could get race, ethnicity, and language preference somehow embedded into how we collect data as a QHP. We're trying to, looking at that and looking at how important that is and trying to advocate for it on the inside. But if we had outside pressure to report, with race, ethnicity, and language preference, it would help a lot.
Colin and then Kieran.
I think it'd be interesting, one, to, first of all, I guess, start looking at the metal tiers and I guess which ones consumers are purchasing, whether it's covering the services they need, and then how the makeup of what consumers are choosing in New Mexico compares to other states, and then what sort of models are those states using to drive people towards more quality plans and making those plans affordable.
Thank you.
This isn't so much an idea about scope as just another plug to really think about using counties as a vehicle to get the information, because we touch every resident in one way or another, and there would be some sort of uniformity, and we could get the consumer to answer your question for you if we wanted to, if we could get unified, and we have the existing mechanism to do it. So.
We already talked about how HSD and DOH are not here. I think low-hanging fruit, in my opinion, is we talked about, it was mentioned in the morning, the SIM grant that the Department of Health has. This is all about health equity. It's about health care, improving access, and lowering cost. So how is this a part of that, the SIM grant, and what Department of Health is doing going forward with the SIM grant in terms of ACA? Because I worked for the Department of Health for a while, and so in my office we did absolutely nothing in terms of ACA outreach, which was shocking to me because it's the Department of Health. But saying going forward, because there are public health offices almost everywhere in the state, including in rural areas, what is going on in terms of that SIM grant, in terms of HSD and Department of Health, because they're the two holders of the SIM grant, going forward, and how are they incorporating this body and the community voice, because there will be community stakeholder groups, but what are they actively doing in terms of ACA outreach, enrollment, awareness?
Can I just address that? I did want to say that the people keep saying about the Department of Health, and we did reach out. We did a lot of reach out to the Department of Health, and there was actually some kind of a conflict with the people who were doing the SIM grant this week. So it was not, the planning wasn't, they weren't able to come, but we did reach out to the Department of Health several times and to different agencies within the Department of Health and invited them to come to this.
Thanks.
Just want to also announce, Trash now said that they're going to have their first big stakeholder meeting for the SIM grant May 19th. Somewhere in Albuquerque, I don't know where and what time, but I'll be sure to ask her to send it to the list so it will be sent out to everybody.
We'll be at the Balloon Fest tomorrow.
Oh, good.
Stakeholders.
I don't think everybody heard that, will you? What did you say?
Oh, I was just saying that the stakeholder meeting on May 19th will be held at SIM grant is the State Innovation Model Grant, and it's a $2 million grant that CMS gave to the Department of Health this year. And the idea is to look at health systems in New Mexico and kind of reconfigure them, and to get lots of input from stakeholders. And they've narrowed it down to 6 stakeholder groups. Thank you. Okay. This is from my briefcase, right? Yeah. So the SIM process will address 3 aims: population health, experience of care, patient experience of care, and per capita cost of health care. There are 5 objectives. 1 is alignment and integration of public health and primary care. 2 is reducing costs and slowing the rate of healthcare inflation. 3 is increasing the number of New Mexicans who have health insurance. And that's the key overlap with this particular project. Building the healthcare workforce and supporting infrastructure, and expanding the use and integration of health information technology. And one of the things I'm trying to do personally is to integrate the work of the New Mexico Alliance of Health Councils on this project with our work on the SIM grant, so that we'll be sure that by hook or by crook we're going to get the information that we seek. And then,
why don't you explain Health Council's role in the SIM grant?
well, yeah, we had a meeting yesterday, most of the afternoon, to talk about exactly that, the role of the health councils. And we're going to be working to get community input that is separate from those 6 stakeholder groups, and that will feed into those. You know, we'll gather information from health councils, working with the Department of Health, regional health promotion teams. And they're, as we speak, organizing meetings with all the health councils around the state to try and get information. Now the trick in this, at this particular stage, is to define the questions to ask so that we are getting the information that we need. And you know, I think the idea is to get from communities and consumers, from their point of view, how they experience the healthcare system, how they experience healthy environments or not so healthy environments in their communities. Mix that into the mix with the stakeholder. We use that word so much, and I can't even pronounce it. And I was thinking earlier today, it's ironic that we're using a metaphor like stakeholders that is drawn from the mining industries. I don't know what that means. Anyway, so does that explain the SIM grant a bit? Yeah.
So could you please tell us who are the health councils? And then since one of the objectives is to increase the number of people who are enrolled in health care, is the insurance exchange a part of that group?
I can't, I'm sure that they are part of the group, those stakeholder groups, and I don't have the list of stakeholder groups with me.
They just reshaped it yesterday.
Yeah, they just reshaped it yesterday.
They had 9 and I think they have 6.
So basically the community input comes first from health councils, 38 health councils, county and tribal health councils, and then that information gets compiled and will be shared with these 6 stakeholder groups that will, and those are more institutional memberships. And they will be meeting on May 19th, as Dr. Carrystone mentioned. So, and then this whole process will result in a design of a health system in New Mexico that then will go back out to communities, and communities will have a chance to respond to that design, and then that will go to CMS. Could lead to really significant funding after that, although apparently they found out just a couple of days ago that maybe that funding isn't there after all. It's, you know, shades of what happens with the community transformation grants and prevention funding with the ACA.
one thing that I've noticed in my behavioral health work is that people that are institutionalized at NMBHI lose their Medicaid. And then when they're released, they're not provided back through the aftercare discharge planning to reinstate their Medicaid. So they're discharged without Medicaid for appointments, medications, services that they need in the community for that support. Another piece of that too, the Native Americans that are there, they don't have the staff that know how to relate to tribal aftercare programs where the people come from, for the wraparound services. They don't know who the referring agent is, how the people got there. So there's a big gap in that area, as well as those non-natives coming out of the system. Excuse me. And if you look at our juvenile system, Sequoia, they're not given part of their cultural activities, are not provided to them in some cases. Families are not part of the treatment planning, discharge planning, or aftercare planning. Well, anyway, short of breath. But these are some of the things that I experienced that needs to be put out there, and those are policy issues.
Thanks, Phil. We have Sunny or William.
Yeah, I guess like since this issue has been a really public and political issue to begin with, right? So, trying to get people, our own people, to sign up for some kind of program, has been really like pulling teeth, right? In terms of, this is why you need to get insurance, and trying to convince them on that level. There's so many negative connotations that are attached to this thing. So, one of the things that I think really needs to be illustrated is like the economic benefits and the way we talk about it. So, the side effects of all the influx of dollars coming in from this program, we need to be able to talk about those things, and that kind of gives us, when we learn how to talk about these things, we can, it looks like it's more successful. And people feel like they can invest in this program, but if they're always looking at the negative connotations of the program, it doesn't give them much incentive to come in and enroll. And so I just think that's one of the things that we need to take a look at.
One more, Dave, just one. Is it okay?
I just wanted to add, I agree with Sunny. I think if we're on this side of the world, we're always like just trying to make it work for our communities, and we're not doing much of how our communities are actually aware of the benefits, or almost like that quote unquote messaging of how this is playing out, because it is very politically charged. But I just wanted to add that on. The other thing, I think that, I don't know how low hanging this is, but I think we did, again, I'm plugging our little survey report just because I want everybody to read it and use it. But so we interviewed individuals that went through the ACA enrollment process, and we interviewed a lot of folks in the room, grass tops folks who were doing enrollment. And I think what we heard a lot was that everybody said all day long that it's most important that we're culturally and linguistically appropriate and reaching communities out to all the far corners. And so we know that that's happening with community organizations that are already existing in those places. So I just like to see how is resources being distributed for how things are getting. If we're all saying that we know that's true and is working best, then what I heard a lot of was like at enrollment fairs, there was like this brokers versus community groups kind of thing going on, and I wasn't part of actually enrolling people, but I heard that there was incentives systematically in place for the number of people you enrolled, which often had brokers saying, okay, we're not going to take that family of 5 people or this mixed status family because that's going to take us longer. Let's just get the people that we're going to be able to bust through quicker. So again, I wasn't part of actually enrolling, so those were just some of the stories we heard as we interviewed people. So I guess to me, if there's a role that maybe is already available to see transparency around where are resources being distributed and how equitable are those resources being distributed, being that we're saying we know what works as far as reaching the communities we need to reach.
Hi, my name is Luella. I'm coming from the nursing aspect of it. I'm a utilization review nurse. You know, one of the things that I see as a problem regarding getting our Native American people to buy into Medicaid is, you know, like I said, as a nurse, we function with looking at medical necessity criteria for a patient to occupy a bed, okay? But we utilize guidelines, they're licensed guidelines, and it's a multi-million-dollar business. But one of the things that they do is everything they put in writing for our patients is at a 5th grade level. If that makes any sense to any of you, a lot of our elders and stuff, we can talk to them and they'll sit there and shake their head, and you're trying to explain something and they're shaking their head, yes. And you can, that person can walk out, someone can come in and say, did you understand what they said? And they'll say, no, I don't even know what they said. You know, so I think when we're gonna put something in literature for our people, I really think we need to consider putting it at a level that they can understand. And I think that would really be a buy-in for our people. Thank you.
Yes, just one thing for people who really want to play the inside game. The New Mexico Health Insurance Exchange Plan of Operation is up on their website, and they are asking for input from people on the plan of operation, and the deadline is May 8th. So if you go to the website and look at the plan of operation, you can give input on, comment on things that you think need to be improved in the plan of operation. And I would recommend people do it if they know enough about the operation to do it. I would recommend it, because those things are things that are going to go directly to the board. Thank you.
So I had one other question for all of you, kind of going along with what Lisa had asked about low-hanging fruit. Many of you mentioned the lack of involvement from the Human Services Department, HSD. What would be the best way to engage them? How could we engage some of those stakeholders that are missing? I know they're hard to engage, but I'm serious. What ideas do you have in this room to bring them into this process?
I guess it's not an idea, it's more of a question that maybe some of you are thinking about, but maybe we need to get a clearer understanding of the implementation and oversight role. Like, is it all up to HSD to implement the Affordable Care Act here? Is it partially up to DOH? You know, does every state need to have an incomprehensibly acronym-laden named grant in order to implement the Affordable Care Act? Like, you know, how does the public know this stuff? These are government functions. This is a government oversight. Public health is about assuring government services and access to them. So you know, maybe a low-hanging fruit would be for us to come up with who in the government is supposed to be the adult in the room and get them here. I mean, and by who, I mean the entire division, you know, and let's identify that division, and then we address our questions to them, because it's not up to grant money, it's not up to nonprofits. These are government functions on how this works. So I'm confused about who that is.
Well, this is something actually my colleague here, Jeremy, brought up a few minutes ago. But I will say, with respect to getting HSD involved, perhaps we, and I mean we, OSI, could be a little more proactive in that regard, because I have taken it upon myself to develop a relationship with the program coordinator at Aging and Long-Term Services, because they're out at a lot of the things that we are, and unfortunately HSD ain't there. And we get the questions. We don't regulate that part of it, so all we can do is refer them to those folks. And it is unfortunate, and Jerry mentioned it earlier, that perhaps we could go out as a team. So having said that, perhaps we can approach it from our end of the fence, so to speak, and reach out to them and engage them more in a lot of the things that we do, because we are mandated by the legislature to go out there and advise the consumer on how we can help assist them and their patient rights. So perhaps if we could take that initiative and say, how come y'all don't come with us when we go? Then we could make it, because we get their questions, you know, any one of us from our office, when we're out there, we get questions regarding Medicaid, and we don't regulate Medicaid. So, and we've developed a relationship with aging, so perhaps we could similarly do something with the folks over at HSD and make it a state, federal/state team when we go out to do these things.
And then one other group that many of you mentioned is missing, consumers, people who are actually using the system, using coverage, and not just involving them, but capturing their voices, their real stories. So what are some of the best ways to engage them in the assessment process? Other than some of the ideas that have been mentioned, like using the counties as an avenue for surveying, but just some other things, other ways that we could capture those stories.
I'm actually going back to the earlier question. You just didn't see me in time. There's a Medicaid Advisory Committee meeting week after next on the 11th. I usually go, Paige usually goes. I unfortunately can't go to that one. And I have gotten more, shall we say, activity from some HSD partners when I stood up and said that I wasn't getting the help I needed in front of the Medicaid Advisory Committee. I got a lot of phone calls the next day. Some of them were not very happy, but I got some action. So if anybody here wanted, from either ConAlma or one of the evaluators wanted to go to that Medicaid Advisory Committee, that might at least get you linked up with somebody else. And if I was going, I would offer to do it. If multiple people in this room are going, maybe everybody could stand up and say something, and probably there's more likely to get a little action.
So using OSI as a connector, I like that one, identify the adult in the room. And then using the MAD meetings, the Medicaid Advisory Committee meetings, MAC meetings, sorry, to get involved. But back to the consumer piece, and again, I'm really looking for strategies that weren't mentioned in the report out. So real people using the system, using coverage, and capturing their voices or stories. In addition to your report.
Yes, that's why I'm talking, because it was difficult to get 200 people that have actually went through the enrollment process, but we offered incentives, so just $5 gift cards to Walgreens is what we offered, and that really helped. We were super successful at using food pantries across the state to gather people, and the only thing I want to mention on part of that is that we had 200 people answer our survey. Our very last question was asking folks if they'd like to take their conversation and their stories to decision makers. And at first I thought maybe we'll get 10% of the 200. We had over 70, almost 80 people check that box that they want to stay in continue communication and take their stories to decision makers. And we were able to take 17 of them to our lobby day. So I just think also thinking, how are we actually building the leadership in those counties, not just taking the information that needs to be anonymous, but who can we pull as spokespeople from their county community?
Pamela, did you have any? I just want to hear Pamela's voice. She joined us late. Do you want to introduce yourself?
This is definitely the spot. So I just want to say it's great to be here, but what we found also, as we were going out engaging, I'm Pamela Herndon, the Executive Director of the Southwest Women's Law Center. So you've been engaging with our staff attorney, Paige Duham, all day today. So that's been really great. But what I wanted to let you know is that as we went around communities, what we found, and this probably has been discussed, is that the best way for engagement was to make sure that we had community people who were involved in the enrollment. So it wasn't necessarily outsiders, but people that were trusted allies who were coming and knocking on their doors and helping them to get enrolled. So we found that consistently, on a regular basis, that if we could make that engagement occur, that we were more successful in getting people enrolled.
So maybe that's a piece of the low-hanging fruit that we can come up with on the assessment is, it sounds like there's agreement that the NAPR model is and I know you can't say this, but Napper who? The Napper model is working for reasons that are well thought out and well planned. So maybe doing some development around that. It shouldn't be too difficult to clone this model and fund it, or maybe increase the fund, or whatever, but that might be a low-hanging fruit that we already have in our midst.
Thank you, Terry, and I didn't hear that, I'm not wearing my napper. I guess with that, if there's other questions, Lisa or members of the assessment team or Nadine, who's looking at the process, are there any other questions you'd like or feedback from the group before we wrap up? Barbara, did you?
I just wanted to throw out another form of assessment, certainly not assessment, and a number of young people dealing with. And we haven't done a lot of it in New Mexico, but I think it'd be a great opportunity to engage some of the youth groups, college groups in doing photo research. And at our table, we were asking, how do you do the social determinants of health? I think it's a great project for photo research for young people to look at and gather some data for us. And with that, I'd like to turn it over to Dolores to close us out. Or, I'm sorry, describe the next steps.
First things first, there are some pastelitos there, folks. We had our break a little bit earlier, so please don't be shy. Feel free to get a little snack. So a couple of thoughts. One is, I want to just kind of reiterate that the Affordable Care Act is not the be-all to end-all. It is one major policy change, a profound policy change in healthcare reform for our country. So there are many aspects to ACA that we didn't get a chance to talk about, but one of the things that Sonoma is going to do as a next step is we are going to pull out the ACA provisions related to advancing health equity and share them with all of you and others that are interested. And then part of our assessment project is then going to be on the next column is to add what is happening in New Mexico. So just one example in terms of one of the provisions that we didn't talk about too much today is related to workforce development. So, for example, workforce development ACA provision includes funding to train low-income individuals as home health aides and other healthcare paraprofessionals, secondly, investing in historically minority colleges, providing scholarships and loan forgiveness for primary care providers, and increasing the use of community health workers. It includes strategies to recruit racial, ethnic minorities into healthcare provider and leadership roles. That's a big piece. We didn't really talk about it, but it's a very big piece in terms of how ACA can advance health equity in New Mexico. So that's going to be part of what we do, is pull out all of those different elements, and you may have others that specifically relate to advancing ACA and health equity. And then, getting your feedback in terms of how your groups or others are participating in that. The other is alphabet soup. We've heard lots of alphabets today. And I think that we can also do a better job of, really explaining, like someone asked, what is the SIM grant? I think that we can't assume that we're all on the same page. That, we do kind of define these words or acronyms so that everyone, is on the same page. I think that's a piece of the health literacy and health education that, we can all do a better job of. The other is that any major policy change, I used to teach social policy, any policy change, there are people that are advantaged and there are people that are disadvantaged. So we want to pay attention to, the different perspectives
because one of the dangers of this kind of work, and the reason that we work so hard in terms of diversity, is groupthink. So we want to make sure that we bring people to the table that not only share our perspectives, but have other perspectives that we may not have thought about. So, you know, keep that in mind as you're going around about your work as well. And then I want to close with what I started with this morning in terms of the new U.S. Surgeon General and his statement that health equity is a civil rights issue. That's profound. We have not had that. We have not had people in those positions that take that kind of position. So although we've talked a lot today about what's wrong and what we need to do, you know, I want to leave on a positive note that the ACA in general has done a great deal in terms of advancing health equity. And I think that with your help that we can continue to do that. So thank you all for being here. Thank you to our panelists, to our project team, to our staff, but most of all, thank you all for all that you do.
We don't leave quite yet. We have an evaluation. So a big part of this project is we have Nadine who's doing the evaluation, and
Yes, they got passed out.
So that got passed out already. If everybody could return that back to Dennis.
So you get a pastelito, did you turn in?
Yeah.
Maybe get one over here.
And you haven't lived unless you have tasted those pies.
Right forward.
Nice seeing you. Okay. Have a good afternoon. I wrote it on my thing, but did a lot of tried to get off of
Ha ha ha.